I do think she said everything about me, so I don't have to introduce myself. Unfortunately, usually I do it. But let's say that what I'm going to present today is probably straightforward. I'm not going actually to be as sophisticated as Yura or other people before me. It's just imaging of occult, traumatic stress and fracture. Something that she said is true. I do have a lot of osteoarthritis research, and unfortunately I was asked to do something else, even though I wanted to do that. I hope I would be successful in what I'm going to do today. It's very easy. I can actually, this first slide, and it can be the last slide. There is an ACR guidelines, American College of Radiology, that I'm going to read to you. And it's about, do not forget that the patient, when he has pain, after fracture, after trauma, please do something else if you think that maybe you're missing actually that fracture. That's it. You can go home. No, the American College of Radiology says that an occult fracture, as definition, is a not radiographically apparent or demonstrate a saddle abnormalities that are missed at initial interpretation. That give us a leeway. It means that as a radiologist, we can miss fracture. Well, that's good. But you will see that some of the images I'm going to show you, they are really from the day that they asked me to do this talk to now, that resident will come back to me and they said, oh, you're looking for occult fracture. This is one that we missed. And you will see that, unfortunately, in the United States of America, sometimes it's a little bit worth it maybe for a patient that the doctor will miss fracture. I'll tell you about the amount of money we paid some of these guys, unfortunately. So it's, if you base actually a fracture on only X-rays, sometimes you can miss it. That's what it says as well. It can be confirmed by other imaging, so think about something else. Or if the plain radiograph is reviewed in retrospect. So that's the leeway. You can go back and say, oh, we missed it, but it's there. Now, it's very important, and that's actually definition also of the next slide. It may represent fractures, traumatic fracture. It can be insufficiency stress fracture, or it can be a fatigue stress fracture. And I will explain those. Now, an occult traumatic fracture, that's the first one that we can miss, is a traumatic fracture that may be subtle to be visible on standard X-ray, or maybe superimposed with adjacent structure. That's, for example, the pelvic. We see the pelvic. We have a lot of actually structure that are, of course, superimposed. There are also gas most of the time. And you can just see that you miss that fracture. Now, from the stress fracture, those are the definition now. Insufficiency stress fracture, this is by ACR criteria again, is produced as a result of what? A normal physiologic stress. So you have a patient who has a normal stress. He's walking in the street. Everybody walking in the street, but this patient has something wrong with the bone, osteoporotic bone, so you get actually insufficient stress fracture. The second one is a fatigue stress fracture. You have someone who is doing more than expected for the bone. The bone is normal, but it's more than expected for the bone get the fatigue stress fracture. I'll show you some examples. And lastly, this is a definition which is from 4 years ago from the ACR again. This is based on MRI, what we call a stress reaction. So you have a hyperintensity on T2, and you don't see that line of fracture. You have an equivalent of a stress fracture. You have an equivalent of a microtraumatic fracture. So you need to treat it exactly as a fracture. You see only hyperintensity on T2, and I'll show you some examples, but there is no line of fracture. Now, the radiograph, it's very important, is the first step. And this is where actually we need really to be aware. This is where it comes to legal. I mean, they go back legally and see what's happened here. You missed a fracture. Maybe why? Because you don't have the perfect technique. And that's what happened most of the time. You don't get the perfect technique. So it's our responsibility to repeat that examination if again, this is by ACR again, okay? So if we have actually a bad technique, we need to repeat it. We cannot say, oh, we have these radiographs, we cannot see the fracture, that's about it. Someone else would come and say, you didn't do the right radiograph. The second one, it has to be the two orthogonal views that we know, and they are necessary. The knowledge of normal anatomy, that's intrinsic to us radiologists, the through actually a systematic review of the X-rays, and of course you gain more expertise when you are older with gray hair. Now the MRI is comparable to CT. It has much more sensitivity and specificity, and essentially you have a hyperintensity which is on water sensitive sequence or T1 weighted, hypointensity, which is in general irregular, defined, and within that hyperintensity, within that hypointensity on T1, hyperintensity on T2, you have a hypointensity line. It can be regular or irregular on T1, T2. That's the fracture. Now, CT, you have actually two possibilities here, or either a sharp lucent line or a brag continuity of the cortex. And as I said, the MRI is probably more sensitive and specific. Some of the review by Al-Khoury from Iowa says it's 100% sensitive and specific as a technique. Now, for example, I'm going to just go to the examples because that's what you want to just see here because we are all radiologists. So these are the examples. I'm going to come with the start with the occult upper extremity fracture, and I want to say that they are rare. Most of the time they are scaphoid, as you can see. 60 to 70% of the fracture of the carpal bone are on the scaphoid, and 10 to 15% of the scaphoid fracture are missed. So we missed really a lot of these guys, a lot of the scaphoid fracture. Sometimes the occult radial fracture that is supposed to be, we go actually for a scaphoid fracture, but we miss actually the radial fracture because we don't look at it, and that's 14% again from this paper from 2006. Now, this is a patient, 26-year-old male after assault. We have a lot of these at Boston. We are a trauma center. We have a lot of assault. We are located in a region where it's a little bit actually, I would say, dangerous because 4 blocks from actually when I work, there is this part of the city called Dorchester, and I don't know what happened to them. At 6 o'clock in the morning, they start fighting. That's what happened. When I'm on call, that's what I find. Trauma and fighting. Now, as you can see here, with even the scaphoid view, there is nothing. You look at this patient, unfortunately, you miss, and 12 days later, just 12 days later, you see the waist fracture here, very typical, maybe even some sclerosis starting here, and it got actually there's orthopedic hardware put in there, screw, but of course the result is not really convincing because most of the time you have an osteonecrosis of the proximal fold. This is another patient, 18-year-old soccer player after fall. So we get actually again the maybe what we thought is the best technique. There is a little bit of maybe soft tissue swelling here, not really that much. But when you look at the patient, because it was very painful, the CT scan shows this very subtle line, which is still there. It's actually a fracture, and you see the MRI is better here, sensitivity and specificity-wise. You see the fracture here on T1 weighted, the fracture on T2 weighted, and the of course here the bone damage. So again, if you are really about saying, I have someone, he's painful, there is a lot of pain there, suggestion of fracture, I don't see it on X-ray, go to the next step, do not miss that fracture. This is an example of actually what you think a normal X-ray on AP, which is true, there is a little bit of soft tissue edema, and this is a chip fracture of triquetrum, which is very easy. It's not really a missed fracture, but I want to just show it to you because it's really very important. 30-year-old man after trauma. This one was actually missed, and by the way, I'm still, I showed this actually in 2 other conferences because this is an old one, it's dated from 1.5 years, and I'm reading actually here, 14-year-old male, semi-professional BR player. I know amateur, which is like me, professional, the one that you see on TV, on BN and sports, but semi-professional, I have no idea what does it mean. But if you have an idea, please let me know. So there is no trauma. It's probably microtrauma. And we went actually very, I think we were very fast on this one. Again, we missed. You can see a little bit of actually here, periosteal position. As you can see, it's very, very subtle. And here in this radiographic, it's even more subtle here. But when you look at actually the CT scan, you see very thick periosteal reaction. So it's really a subacute or chronic maybe fracture here. You see the fracture by itself, which is very well delineated, and on MRI you see the hyperintensity, and the line as well. So again, even soft tissue edema. Again, when you are a subtlety there, you may actually go to the next step, which is of course CT or MRI. This is a case where you have a 51-year-old male. Fall on ice. We have a lot of ice as of today. Right now we're talking, and it's snowing in Boston. And I escaped that. I'm very happy because last week I spent 8 hours shoveling at home. So I left my wife; she's doing it. Don't tell her. The patient came with a suspicion of fracture the first time. We did an X-ray. doesn't have fracture. We came back, actually we said, okay, a week later the patient came back to the orthopedics, said, I'm still having pain. He said, probably you have rotator cuff tear. So here we injected actually, of course, the contrast, as you can see, and we came actually to the next step, which is the MRI. And as you can see, he has actually labral tear, yes, it's true, but he has a fracture, it's not a non-case fracture of the greater tuberosity. As you can see with the line, which is irregular here, and bone marrow edema, seen also on the T1 weighted surgical image. So we really went actually for something happening to the rotator cuff, and we end up saying the fracture has the patient has a missed fracture. Pelvic fracture are very difficult, as I said, before, because of the anatomy. Sorry, the anatomy of the pelvis. It's a little bit. Of course, there are so many bones, and there are some, interposed. There is actually the curved configuration, especially the sacrum, overlying actually ball and gas, and most importantly, most of the time, you have a patient who is 60 years old and above, and what happened there is osteopenia. And the first thing what we're going to say in a report in radiology is that osteopenia is there, and that may actually, of course, decrease the sensitivity to our actually, of course, fracture. So again, I don't know about what we do here, but in the US, that's what we do all the time. We said osteopenia will not actually give us the opportunity to get the best report in the patient, because we know that osteopenia can give you a hard time looking at fracture. Now, the most common site is the sacrum. I'll show you some examples. Very important to say that sacral fracture, pubic rami, and acetabulum marrow edema may appear amorphous and may mimic sometimes actually metastatic disease. Importantly as well, the stress fractures of the pelvic girdle may occur in military personnel, and I know that you have a lot of military personnel coming actually to the hospitals here, so really very important. And also at fitness level, athletes at all at fitness level. Now, this is actually the case of the sacrum. I tell you, there is a fracture of the sacrum, because you see it here on the CT scan, and you see that this patient, who is a 61-year-old female with renal osteodystrophy, so some osteopenia there, you cannot see anything in the sacrum. You can actually sit there forever, and even actually retrospectively, we don't see it. Now, this patient has it's 29-year-old female, atraumatic buttock pain, and she's taking steroids now for 9 years for an SLE. And if you look at the images, again, it's actually a sacral fracture. There is nothing. And when you go actually to the MRI, you see the subtle hyperintensity, of course, here, hyperintensity here, hypointensity on T1, and there is actually the fracture here going all the way down. You see it here, the fracture in the sacrum. In the ileum, this patient with a 25-year-old male, esophageal pain for 3 weeks. We did actually X-ray, was completely negative twice after 3 weeks, and then we put actually some MRIs here, and as you can see, there is a hyperintensity within the left iliac bone. There is no line which is hypointense T1, T2, and this is what I said, by the ACR definition, we call it a stress reaction. So stress reaction, again, it's a hyperintensity on T2. There is no correlate from hypointensity from actually that line, which is the fracture, so it gets to some reaction, or bone marrow edema reaction, or how we call it actually stress reaction. This is a pubic ramus with a patient of 61-year-old female. Again, there is actually, of course, this spot, this spot here image, and we cannot see anything. When you look at actually the CT scan, you see the line here on the pubic ramus, sorry, superior one. You can see it here with that fracture. So again, you need really to look at actually at the images, and then when you cannot see anything, maybe go to the next step. Now this one, it was actually missed by us, by the radiologist, and as you can see, it's very easy. We did actually the X-ray. We thought it's negative. This is a 49-year-old female after fall, and you see here, of course, the posterior acetabulum. It's actually with a fracture in the block. But when you come back to the image, you see really the fracture here. Again, this fracture was missed by a radiologist. We didn't get actually any problem with this patient. She got treated through fixation, and she was happy. Now, this is a patient who is a soccer player, 25-year-old male with a lot of pain. We did actually the X-ray twice as well. We find nothing, and when it comes actually with left groin pain, it's still there. 3 weeks later, we have these guys coming actually from Boston University, on Boston College. We take care of them. And as you can see here, posterior acetabulum this time has this hyperintensity. There is no line actually there from the perspective of T2, T1. This is again a stress reaction. But it should be treated as any actual fracture. When it comes to lower extremity fracture and the hip, we have actually this, we see it all the time. Osteoporotic hips are, of course, amenable to a lot of fracture. They are usually a little bit difficult because you have a lot of osteoarthritis, so a lot of osteophytes that can be a little bit problematic, and as I said, osteoporosis as well. MRI is good there, it's 100% sensitivity and specificity again. So when you look at this patient, very nice examples where you need really to make sure that you are treating the patient the right way. This is an 80-year-old male with a prostate cancer, atraumatic hip pain, and as you can see, the only thing you can see here is big cystic changes at really a location which is typical at the neck junction, and this is what we call a pit herniation or herniation pit. And we said this, maybe it's actually fragilizing the bone, but we didn't think that there is anything else. And when it comes to this patient, came back with pain, you see that through that lesion, and I can show it to you back and forth, it's absolutely fine. You can even take this off, I really don't need it, but you will see that there is absolutely no actually fracture there. The fracture is visible here after a week. You see the fracture, and after 2 weeks, look at actually the collapse of the whole actually, the whole head of the femur collapsing from, of course, the metaphysis. So again, it's really very important when you have such a thing, such a pain, patient with pain, you get the X-ray. The X-ray doesn't explain the pain. Go to the next step. This patient could be probably treated. Otherwise, maybe we can put some, cement there, consolidate actually that pit hernia or herniation pit, as we do it actually all the time, and then maybe treat the patient with a screw. Right now, it's impossible. It's over. Unfortunately, the patient has to have a total hip replacement. Another one where you have a 55-year-old atraumatic left hip pain. You look at it again, there is the spot image, as you can see here, there is nothing. You look at the MRI, there is a line there, which is obviously we've done even before the scintigraphy. Again, we are a big trauma center, and they come from all other places, and I can tell you, we miss a lot of these guys because still we don't think that we have to do all the MRIs and CT on these patients. But this patient came back a week later, and you see now the this patient has an AVN. We have a lot of also a sickle cell disease. This guy is with sickle cell disease, 47-year-old. You see that he collapsed actually completely the head of the femur at the right side, but he has pain, and the pain not explained by the AVN. So we went back and forth. We told him probably the AVN, probably the secondary osteoarthritis, but he came actually back 3 times, one of them at night, and we did the MRI for the patient. And again, you see bone marrow edema, which is quite interesting here in the peritoneal region with actually the line on T1 and T2. It's hypointense, so a fracture there on the patient that was missed on the X-ray. This is a patient with pain, 28-year-old male, right-sided groin pain. So we've done actually this for groin pain, and ultimately we find out that there is a large, I'll call it actually large size bone marrow edema with even actually some soft tissue edema. We looked at this patient back and forth because we're looking at maybe as differential osteoid osteoma, but there is no nidus there, and the patient actually, of course, never had that pain, nocturnal pain, etc. So really new pain, and from this perspective, again, stress reaction. For the limb or the region around the knee, we know the lateral compartment is very important. So it comes to a lateral femoral condyle, also posterolateral tibial plateau. Many injuries that can actually explain that, and ACL mechanism is some mechanism that you know. And we know that by a brachiopsy 2 years ago, where you look at radiology, find out that 70% of the occult fracture after an ACL injury are actually overlooked by radiologists, which is a big number. So looking at the MRI, you miss actually those. This is an example, very easy, 20-year-old male after a fall from 14 stairs, unfortunate. You can look at these images, they are absolutely normal. And I can tell you it's a femur. Look at, even actually at the CT, didn't show anything. And when you look at the MRI, you see here the fracture. You see the fracture here line, it's a small line here with actually bone marrow edema, and also a stress reaction in the posterolateral tibial plateau. This is a case where a senior guy working with us, trauma guy, he's been actually forever, and missed this one. Because when you have 340 radiographs that you look at from 7 to 7, you understand that sometimes you miss these guys. And you may say, oh my God, I cannot miss this. Even I am a resident, I can see it. I agree, because when he showed it to me, he was devastated. He would show it to me. I said, there is a fracture. And he said, listen, I have a legal issue with this guy, because he went to justice. He got his lawyer. And in fact, you see the fracture here, step off a little bit, not really a subtle fracture, but happened to 1 week later to be really a huge fracture with collapse. He got $5 million. So if you want actually really, you can come to our hospital, you fall into our hospital and think that maybe someone will not see it. It's a lot of money, and I have to say that the guy has actually now really a collapsed knee. That's the problem. And to be honest, the guy after 1 month just resigned and went to write a book about medicine in America. He's not a radiologist. I'm serious. 20-year regular jogger, and every single person working with me right now, when he sees this, he look at the radiograph 3 times. Because again, this was missed 3 weeks ago. Simply because the guy was a new actually resident, first year he didn't see it, was signed up by someone who is doing body imaging, and unfortunately they missed actually this guy. Now 20 years regular jogger, you have a little bit very subtle on this spot image. I don't know even if you see it. Very subtle periostal reaction of subacute nature. And when you look at the CT, you see that it's subacute. Yes, it's thick. You see the fracture, and you see it on MRI. Now again, this guy is a jogger. He's coming with a little bit of pain. So what you want to just do, really make sure that you don't miss such a fracture. A guy who is 20 years, who is jogging, he would not come to you if there is no really reason, there is no actual pain. I'll finish with the occult fracture of the ankle and foot, to say that they are not common. Most of the time they are on the lower neck and talar dome. And I'm going to show you a few images here that are astonishing, because really you don't think that you're going to miss this fracture. So this is a 13-year-old male, and maybe, because we have Zeneva with us, maybe there is a fracture here, no? Maybe. A subtle one here, maybe, no? Just here. But you don't see anything else, no? And the CT scan shows you that you have actually a fracture, yes, where we found it, maybe, retrospectively, but there is other fracture which is here on the fibula that we don't see. Now again, it's really an obvious fracture on the CT. You're gonna say, oh my God, how I'm gonna just miss this one, but we miss all of us, we miss this kind of fracture by any means. Now another patient, 49-year-old male, after 12, the radiograph deemed to be normal. The first time when we went retrospectively, we said, oh, there is here. Look at this. There is a one line here superimposed of periostal reaction. This is written in retrospect, because this patient came back with this. We did the MRI for him, and you see the fracture here, very obvious now, and he started probably where we said the first time he had even scintigraphy. So again, the pain, you see the vitamin E capsule, because the guy was pointing at the pain with his finger. He said, I have pain here, so we put the capsule there, and that's the fracture. Again, 1 month later, the fracture now on X-ray is complete. You see it very well. There is actually a process of healing here, but still the fracture was missed at the first time. This is again a fracture that we missed the first time, very subtle. You see it now actually in retrospect, but you see it on CT without any problem. Now look at this one. Again, the talus. I'm going to tell you, this is a fracture of the talus. Yes, it is. Because we know, a sportsman, 25-year-old male, with no trauma. It's a young guy. You don't want to just miss the fracture. You look at the X-ray the first time, the second time, and you say it's normal. I cannot see it. He came back 1 month later. 1 month later, you look at the images. Do you see anything there? I don't see anything. Now, when you look at actually the MRI, it's actually fragmented in three pieces. A big bone marrow edema, a big actually line here, double line, so it's a complex fracture that is not seen on the first X-ray, on the second X-ray 1 month later. So again, it's really all about pain, and superimposition of those bones can actually tell you that sometimes you have to go to the next step. This is even, for me, this is even more complicated, because I don't understand when it comes to talus. Yes, there are some superimposition of other bone. The calcaneus normally, it's really very easy to see. And as you can see here, we're looking at the subtle fracture, and we thought that we didn't see anything. Now, we didn't see anything. Even if you think about it, you said, okay, the patient still have pain, I'm going to do a CT scan, and you think that you're going to find something really subtle. This calcaneus is in pieces. It's shattered. So sometimes when I showed this actually to my resident after it happened, oh, they said it's not the same patient. They went back with the MR number and checked actually if this is the same patient, and in fact, is the same patient. So that's actually where it becomes a little bit complicated again. And I do think that the message here, when you have someone with pain, you don't understand the pain, but, and the pain is constantly there, do something else. Navicular. I'm going to tell you, do you see anything in navicular? This is no trauma, history of osteomyelitis. We said no trauma. Again, we look at the navicular, we said there is nothing. We look at all bone, we said nothing. And if you look at now at the MRI, it was done for osteomyelitis, by the way, as a matter of technique. And you see here the navicular hyperintense and the line of fracture there. So again, I can go back to the image, and you can look at the navicular. There is nothing there. Lastly, metatarsals. We know that they are also prone to some fracture, but most of the time we don't think about the fourth and the fifth. This is 26-year-old male soccer player with ankle sprain. And what happened, we looked at actually the X-ray the first time, the second time on the metatarsal. We've never seen anything, and as you can see here, the second, the third, where we think that sometimes there is a stress fracture. There is nothing there. We looked at the fourth because he was pointing at the fourth, fifth. So fourth and fifth are okay. And when you look at here at the MRI, you see that there is a large bone marrow edema of the metatarsal base here. And you look at the hypointensity. There is a hypointensity there of the fourth metatarsal base, as I said, and also some hyperintensity at the lateral cuneiform. So again, look at actually this from the perspective of the patient still have pain. I'm looking at something, I don't find it, I go to the next step. The patient has a real fracture of the fourth metatarsal base and a stress reaction on the lateral cuneiform. So in conclusion, as I said, it's exactly what I said in the first place. I don't want you to look at the slides. Remember, you have a plain radiograph. It has to be done the right way. Technically, it has to be absolutely perfect. Then, if you get actually the technique actually done the right way, so the technical perspective is actually there, you want to just also look at the anatomy and look at really at the anatomy the right way. So two orthogonal most of the time views. If you have actually a oblique view, it's even better. And then if you think that the patient has pain there and the pain is not explained by the radiograph, go to the next step. It can be a CT scan. It can be, as you can see in MRI, it's much more sensitive and specific, or even nuclear medicine if you don't have those, actually CT or MRI. But just actually go to the next step. Don't actually allow the patient to go home and run again without